Thank you for the introduction. I'd like to thank the organizers of the conference. It's really been wonderful coming down under. I've been here enough time in order to sort of get acclimated to the time zone. People have been very generous by giving me time, which is seldom done at home. And what I'm going to talk a little bit about is bending the HIV epidemic sort of globally among men who have sex with men and the contribution of sexualized drug risk and HIV risk among this population. And part of the reason why this is really important is if you take a look at the global HIV epidemic, approximately 37 to 38,000 people living with HIV, and there have been huge initiatives around the world to roll out antiretroviral therapy, treatment as prevention, U equals U, undetectable equals untransmittable. And this has actually made incredible traction such that there has been truly marked reductions in new infections because treatment as prevention works, but also decreases in worsening of individual health, that is morbidity and mortality. So we've made great strides. These strides, unfortunately, have been incredibly unequal. And they have been unequal in that key populations have not benefited as much. A lot of the efforts have actually been done in sub-Saharan Africa, but even within those settings, there are ongoing epidemics among key populations where HIV is highly stigmatized. And then if you layer onto this the added stigma of drug use and the criminalization in many places of homosexuality, criminalization of drug use, all of these factors converge in order to have sort of the perfect storm for an ongoing epidemic where much of the generalized epidemic is being controlled. And so part of what we have to do is the UNAIDS has set up pretty stringent guidelines. It used to be the 90-90-90 rule, and that is that you get 90% of people diagnosed, and of those 90% or 81% of the total population of people living with HIV onto antiretroviral therapy. And then the last piece of that is to get 90% of those suppressed. Those numbers have just recently been revised, so it's the 95-95-95 sort of strategy. And we are a long ways to go as it relates to men who have sex with men. Now, I will say that the work that's been done here in New South Wales has been sort of exemplary. There's a lot of really good stuff happening. But the other part of this that has not had the same amount of attention globally is the other part of the treatment cascade. So there's the 95-95-95, but then there's also the prevention cascade. And the big player on this, even though we have a number of tools in our toolbox, has been PrEP. And so this is going to be one of the sort of major features that I'm going to bring together in this presentation. I'd like to thank a number of people who have really helped me think about and conceptualize and provide slides for the talk from Malaysia, where I just came from, my colleagues at Yale, Steve Shoptaw at UCLA, George Woody, who's done some work with stimulant treatment from University of Pennsylvania. Michael and Rebecca have helped me think about a number of new issues. They've got an incredible paper that's going to come out this next month, and it's really a tour de force. It is packed with information. And then Thomas Guadamuz, who's from Thailand, who's doing some fairly interesting stuff around this work. So where are we with regard to the amphetamine epidemic? I'm going to sort of narrow it down to men who have sex with men, but there's over 34 million people who use amphetamines. Amphetamine use is associated with markedly elevated mortality from a number of different things, and these are places to potentially sort of think about, where people are along the spectrum of their substance use disorder. So suicide, overdose, cardiovascular disease, and stroke, accidental injuries, and homicide. But there is also an array of syndemic or comorbidities that come along with amphetamine use, and whether it's the chicken or the egg with underlying psychiatric conditions. In some cases, we know that people come into their substance use without them, and they emerge with these psychiatric disorders. And conversely, it can be exacerbated by the use of substance use disorders for those people who have them. And for those people who are not sort of motivated and that are depressed in their life, that may be one of their sort of outlets. They may have injuries. One of the things about amphetamines is that it can cause neurotoxicity. The dumping of dopamine causes some retrograde death of axons, and so patients can develop pretty significant neurocognitive impairment. And as we begin to talk about some of the treatment issues, this neurocognitive impairment is really important because there needs to be some kind of cognitive remediation as part of this healing process that people sort of use to sort of deal and cope with their underlying amphetamine use disorder. And then, of course, in many places, because of the context of criminalization of drug use, many people are put into criminal justice settings. In some cases, I just came from Malaysia, they have these compulsive drug detention centers where people are put in without any due process. The World Health Organization has called for an end to these. But all it takes is for mom and dad or the police to sort of go check a urine on Johnny or Muhammad, and then you go and you get locked away for 2 years without much of anything, and then you're released back out into the community with not a lot. As we bring it down to how this is concentrated among men who have sex with men, and we could spend a lot more time talking about the why and the how. The bottom line is that methamphetamine use is 20-fold greater in terms of use among men who have sex with men relative to the general population. And a term that has emerged, which is sexualized drug use, that is, the use of club drugs or these other sorts of things in the setting of sex, is associated with an increased risk for HIV across a number of different studies. It's associated with having more sexual partners. There's this disinhibition. Things feel good with the club drugs. Things also feel good with sex, so you have dualized reward, if you will, under those processes. More sexual partners, more condomless sex, this disinhibition. Also, there's a higher prevalence of HIV among individuals who use methamphetamine, so your pool, that is your infectious risk, is higher by coming into that pool. And then there's also been multiple studies that have shown that there's an elevated incidence of HIV among those who are users. Now, we are in Sydney. We are at one of the two big epicenters for methamphetamine use. So we have the production that happens. This is very cheap to make. You can make it in your bathtub. You can go buy some Sudafed at the pharmacy. There's all kinds of incipients, so there's complications related to how it's made. But nonetheless, you have your sort of Asia-Pacific region, and most of the export is to places where there's high income. That is, people can actually pay for the drugs, even though it's very, very cheap to make. And so Australia is one of the two epicenters. High-income countries of North America, that's a nice way of saying Canada and the US. There's also sort of an emerging and growing epidemic. And so we've got these two polar areas, but it's not restricted to just these areas. There are differing densities of amphetamine use and among MSM all throughout the globe. Now, the sexualized drug use, one of the things is, even though I'm going to focus a lot of this presentation on methamphetamine, let's just make it very clear. It is not just a methamphetamine issue. It is everything that you can put in your mouth that says, let me have a reward, all right? So methamphetamine goes by a number of different names. It's ice, it's tina, it's crystal, crystal meth, fireglass, crank, speed, etc. It can be inhaled, it can be sniffed, it can be injected. In parts of the world, that's called slamming. There's a number of different names for that. But in the MSM community, it can also be booty bumped. You can actually have inflammation that's happening in the rectum and increased facilitation of transmission. That's oftentimes mixed in these sort of sexualized settings with MDMA, ecstasy. One of the things that's happening with these drugs is that they're sort of releasing dopamine. Dopamine is the feel-good sort of drug, and so it says, aha, you feel great. And then you actually, depending on how much you use, you can deplete almost all of your dopamine into the presynaptic space. Serotonin then comes with a rush with that, the other feel-good drug. And then you can actually have problems with depletion, so maybe 3 days after their use, a person can experience what I call Suicide Tuesday. So you go out and you use on Saturday, and by Tuesday morning, you basically want to hurt yourself because you don't have enough serotonin. One of the reasons I'm bringing up some of these comorbidities and complications of this is because these are going to ultimately be places where I think we need to be intervening, because almost all the interventions that I'm going to present at the end of the talk are really at the end of the substance use disorder cascade. There's also gamma hydroxybutyrate, G. This is essentially Alcohol on steroids, it has a very narrow therapeutic index, so you take a little bit and you feel like you are the greatest gift to men, and you take a little bit more and you go into a coma and you talk to God, all right? So this is a very dangerous drug, all right? And, but it has a very narrow therapeutic window, and people will tell me, oh, how many drops do you take? I take 3 here, you have no idea because you have no idea what the concentration is, but there's a lot of pharmacologists out there, and I have to tell you that there's a lot of self-efficacy around the way that many people use drugs because they're able to use them without a lot of problems. But it is a tough one. And you can imagine that if you're disinhibited from 2 other drugs, the sort of ability was that 3 drops or 4 drops, or who was the person who just squeezed 2 extras because you look really hot and I want you tonight, because it's also one of the date rape drugs. Ketamine, special K, which is a dissociative anesthetic. By the way, I have a little bit of a potty mouth and I'm going to try to behave today, but we'll see what I can do. There's ketamine, also known as special K, black hole drug. This is a dissociative anesthetic. You go into a K-hole, you lay back, have 5 people have sex with you, you never know it, then you come out of it, and then, all is good. Alcohol is often mixed with this in the same way that G is. Cocaine, the epidemics of stimulant use with cocaines are more in North America. There's not a lot of that over here. And in Asia, it's more amphetamine that's occurring, so there's not a lot of cross-use with that. Amyl nitrate, a sex-enhancing drug, is oftentimes used. It causes a dilatation of the blood vessels, so you can imagine if you've got a couple of different drugs that are affecting the cardiovascular system, you can have a compounding effect. All of a sudden, your heart starts racing, and then you add a little Viagra, because one of the things that methamphetamine does is it causes a decreased libido. It's called crystal dick. That is, your dick doesn't work. And so all of a sudden, in order for someone who might identify as being a top or the insertive partner, they take too much of this, they get crystal dick, they become an immediate bottom, so their risk is actually increased by 30-fold under those particular settings. But they can reverse that now because they can take an erectile dysfunction drug, but that also causes dilatation of the blood vessels as well. And so you're sort of compounding a lot of the potential pharmacologic complications from this. I do want to say a little bit about GHB, and I'm going to sort of get there and go quickly. This is a survey from the UK, 2,700 MSM. These are people who've had serious problems. This is really emphasizing the narrow therapeutic window for this particular drug. 63% had serious problems, including loss of consciousness, addiction, hospitalization, and sexual assault. So when you're down and out, you're available for everybody. Non-fatal overdose in a half of them. Sexually assaulted while under the influence, 1 out of 4. Met criteria for dependence, feels good, 14%. It's starting to look like alcohol here. And then knew someone who had died from it, 27%, 1 out of 4. So this is a serious drug, and this is oftentimes something that goes without sort of knowing. But you can imagine if somebody has a complication, this is a place where you can begin to have a brief conversation, because individuals who are feeling the euphoria of these drugs, they're sort of in the pre-contemplative stage about doing any sort of thing, and when that window of opportunity, that golden moment happens, it may be a place to begin to intervene. Now, one of the challenges is that our systems, whether you're on the outside at these various different parties or any of these things, or people come into your emergency department, it's out of sight, out of mind. There's not really a triage system. We heard the narrative about dealing with the system and getting people into various kinds of treatment. And one of the things I'm going to tell you is that we have really lousy treatment for this. And so people throw up their hands, and what do you do under those situations? But motivating people can be a very important tool. And we'll talk a little bit about some of the stuff later that we're doing with apps. So this is a drug and alcohol group, but I just want to sort of set the stage. And for those of you who got up this morning and you had Vegemite, I wanted to choose something that was from down under here. My hotel doesn't provide it. But anyway, why do you eat that in the morning? Not just to sustain yourself, you like it, okay? You get a reward from that. The eating is one of the sort of addictive things. I mean, unlike anything else, with eating, you can't go abstinent, right? So let's think about this as sort of our prototype for this. So you feel good, you feel a reward, but there are different kinds of drugs and different kinds of activities that reward the system greater than others. And one of them is crystal meth. And this is one of the most psychologically addicting drugs that happens very early on. The metabolic pathway goes down the way, and the reinforcement has got to be so incredible. The people who describe this, it is a mind-blowing experience. So when people tell you, when you say, why in the heck would you do this to yourself? It's because it feels good, and you cannot forget that as you're beginning this whole process. Now, other people sort of want to say, well, what's the process to getting addiction? Oh, they come from a bad family or any of these other sorts of things. Well, it's much, much more complex than you think. There are sort of the biological sort of predispositions. From my family, I should be the most addicted person in the world because I don't have anybody without a substance use disorder in my family. I somehow escaped that. I promise I did. But anyway, but biologically, I'm screwed, all right? So I know that. But the other thing that we have is we have environment. So I'm one of these kids who got a scholarship. I went to Yale. I was in a different environment than the rest of my family. And so these two factors can independently move towards the addiction. And you can imagine that whenever they sort of come together with a high risk and a high risk environment, places where it is pushed. And you can imagine if you happen to be out in the world and let's say you're a 50-something-year-old sort of slightly plump, bald man, and all of a sudden you want the confidence to look good and you want to look good to other people out there, it sounds like a really good environment if you want to get laid, right? So you can sort of think about those sorts of things and about how seductive it is. You introduce the drug, there's a lot of biological brain mechanisms that are going in place, and I won't have time to go through all that. And then ultimately, there's this pathway to addiction. But not everybody who uses is going to become addicted. It's going to be a subset, somewhere about 15% of people who sort of transition. As I mentioned before, dopamine is the sort of pathway. These drugs trigger an inordinate amount of dopamine release. You have a number of different pathways, and you get this sort of reward that's happening. And it's a brain disease. It's all happening within the brain, but it's got protein manifestations to other places throughout the body. This sort of area that is sort of the ventral tegmental area of the brain is somewhat preserved, and there's some cross-cutting pieces, but some subtleties and differences in addiction, which is one of the reasons why we don't just have an addiction drug that treats everything. So there's some subtleties, there's glutamate pathways, there's going to be the dopaminergic pathways, there's the serotonergic pathways. So we keep coming up with, sort of medications and treatments that we might be able to use, and one drug isn't going to fit all as we come across the way. This is really just to show you different pathways. This is the brain. I hate these sort of things. This is your brain off drugs, and this is your brain on drugs, all right? The head of NIDA used to do this sort of thing, but this is actually Nora Volkow's work, who is the head of the National Institute on Drug Abuse in the US. And whether you're on cocaine, methamphetamine, alcohol, heroin, I could show you the same sorts of things for gambling addiction, sex addiction. It all looks the same. The dopaminergic receptors are lower in individuals who have a substance use disorder at the time that they're being used. And of course, these are sort of cocaine, two of the stimulants that are present here. Now, in order to lay the stage, this is the US system. People use ICD-10 and others, but this is the DSM-5 diagnosis for a substance use disorder, and you can just put in your word amphetamine, cocaine, opioid, whichever use disorder. You have to have 2 or more of these in the last 12 months, and depending upon the number of symptoms up here that you get, some of them are physical, some of them are psychological, some of them are social. All right, and interpersonal. So all of those things are part of the components here, but you can actually have it as mild, moderate, or severe. Now, what I want to do is I want to sort of reposition this because I want to think about the use of amphetamines and how we may intervene, because when I get to the end of the trail, the treatments are really pretty lousy. So we've got individuals who are using a little bit, and we have some that are using occasionally, and they might have problems infrequently. The frequency of the problems increases, and then we get to the point where there is a severe amphetamine use disorder, or sometimes referred to as addiction. However, if you're out in the community and you're thinking about implementing any kinds of interventions, the mentality is the people that we talk to don't see it this way, all right? What they see it as is they see it as fun. They see it as fun with a few problems, and they see it fun with a lot of problems, all right? And so that's really sort of the framework that I like to think about as I'm beginning to sort of deal with, these substance use disorders. But the reason for putting it into this sort of framework is that there are lots of places to begin to intervene that are long before you get to sort of an underlying substance use disorder that is of a severe form, all right? And every trial of whether it's a behavioral intervention or whether it is a pharmacological intervention uses the model that we use for cancer, that is stage 4 disease. We always start out with the patients with the metastatic, most severe disease. And we say, we get a little bit of a hint of something, and then we sort of move it down further on. We knew with HIV, we started only with patients who had an AIDS-defining diagnosis, and then we moved the CD4 count to 200, but maybe not AIDS, changed the diagnosis, the definition, moved it to 350, moved it to 500, and now the bottom line is we treat everyone. I think we need to sort of get out of this old mold of sort of thinking about this, because the kinds of interventions that we do at different stages are going to be really relevant. And what we really don't want to do is we don't want to get to the point where there's been some brain damage, there's some neurocognitive impairment, the cognitive remediation isn't going to happen, and there are times to motivate them. And if you're a clinician who's working in an emergency room, you come in with any one of the complications, it is a call to action. If you are out in the field in the LGBT community, it is a call to action when somebody says something to you. I was just recently in Kuala Lumpur, and there were all of these sort of LGBTQ plus affirming services. They had developed this model program in like one big city, and they were doing wonderful stuff. I mean, no one could ever sort of complain about that. The one thing they said is, we're not really funded to do the substance abuse, so those people do that over there, but nobody's really doing that, so your enabling resources to deal with it are really somewhat challenging. So my fear is that almost everything that we do is going to have to be sort of organically developed from this particular setting. I'm not going to go through all of these. I've gone through some of the complications, but I am going to go through just a few in terms of where they relate. But basically, the methamphetamine can have numerous consequences. There's a lot of people out there who are not having any, and that will be one of the challenging places in order to meet people where they are. So if we sort of start out with the early sort of place where it's fun, where might we be able to do that? Well, what they're going to feel at that particular point is mostly going to be euphoria. They might have a little bit of tachycardia, they may have some flushing, they may have that Suicide Tuesday experience 3 days later, they may have a little bit of nausea, but for the most part, it's mostly going to feel fun, and that fun is going to be accentuated when it comes to sex in that particular setting. If we, however, start moving to the point where there are some kinds of complications, medical consequences, that we can begin to start to do things from an emergency room, from a primary care provider. It may be at the place, if somebody goes in for HIV testing, it's a place to do a screening, a brief intervention, and maybe, even though brief interventions and systematic reviews have not worked, and they've worked some for alcohol, but the referral to treatment doesn't work, you have to make sure that you've got a sort of some kind of treatment that's available. And then, of course, when we start to get to the very end, the sort of consequences that can happen there is cardiovascular disease, strokes. That can actually happen with a single-time use in those settings. Patients can be predisposed to seizures, overdose and death. One of the most disturbing things for patients is when they developed a psychosis induced by amphetamines. They're hyperstimulated in these settings, and the treatment in those places, whether it's in the LGBT community, out at someone's house, or whether it's in an emergency department, is to reduce the stimulation around them. So that's a really important part. There can be some body dysregulation with regard to temperature, but there can be some somewhat significant consequences that occur with advanced disease. The other thing that's really important before you sort of get down to the end point of the disease is that the recovery of the brain is going to be very important. So once again, this is Nora Vocal's work. This is a normal brain control, and I apologize, the way that she created the slide, I tried to cover it up, but it's going to show back up as using the word abuser. I don't like that term, but anyway, you'll see that I called it meth user. It's going to come up in a second as an abuser. You can see that the dopaminergic pathways are sort of blunted. In this particular setting, this is 1 month after detox. So this person has come into a detox program, and it's 1 month later. There's still pretty significant damage to the dopaminergic system in that setting. It really takes a long time for, and I don't want to use the word recovery that we think about with the treatment, but brain recovery that occurs. It takes a lot longer for this drug relative to opioids and to other drugs. And so making sure that we have a longitudinal plan, not just a quick detox and say, see you later, folks, but really about having a sustained engagement with individuals over a prolonged period of time. Here comes the meth abuser that comes up as a bill in the slide. Let's go to HIV. There's going to be some great data that's coming out on what it looks like globally in terms of the attributable fraction. These are data from North America, what I call the up and above as opposed to the down under sort of epidemic of amphetamine use. And it's somewhere between 16 to 32% of the attributable fraction of new infections, at least in the US. It's happening in young people for the most part, and it's happening with people who have money. They have to be able to buy these drugs, okay? So this is when you begin to think about how you're going to intervene, I'm sorry, if you've got a nice little car outside, that's a nice fancy car, the sort of contingency managements that I'm going to talk about, what is the reward that you're going to be getting unless you're sort of down and out and on Skid Row? We did a really interesting study that I think has a lot of telling things about what's here. This is not published yet, so you're happy to see it, and we've presented it at conferences. But what we did was we took 50 MSM who were using amphetamines, and it was basically any use in the last 30 days, and that was a requirement. It was in Malaysia, so it was at a place where we had to do almost all of our work virtually. We developed an app so we could do micro-longitudinal assessment, and we assessed them every single day. Did you use or not, and about how much? Did you use other drugs? Did you have sex? Was it with a condom? How many partners? So we really tried to look at this issue of concurrency. And what we found is that of these people, and this is actually a really elegant sort of piece of this, is that we had basically 50 individuals. We observed them every day for 60 days, and we had 93% of the data points that we could look at, which means that you have sort of a richness of being able to look at what's happening on a day-by-day basis. And this is missing from a lot of the studies, because when we sort of present the urine toxicology, if you happen to do the urine toxicology on Thursday, you're missing Friday and Saturday use, okay? Because the drug testing is 3 to 4 days. So urine toxicology is not as good. This is really getting at how you might do some of this. 25% of the days were spent using amphetamine. 58% of those that involved sex. We had essentially nearly 600 days of sex. A lot of that was without condoms, 80%. And you're going to see one of the things that we learned in this is that the overlap or the concurrency is incredibly great. And there were 346 days where there was concurrent condomless sex and amphetamine use. Incredibly high correlation of use on those days, and you can see that 50 to 60% had the opposite going on at the same time. This was in the pre-PrEP era. PrEP is just barely being introduced in Malaysia, and so we have this high concurrency correlation. What's interesting is that most of these people are weekend warriors, and what it sort of speaks to you about is, for those of you who come from the alcohol world, it's that context of binge drinking. This is your binge drinker group, which may not respond to some of the interventions in the same way that people who actually have dependence, all right? So let's think about that a little bit in terms of how you do things, but also how you assess individuals in some of your studies. Some of these people were already HIV positive. We had 3 seroconversions over a 2-month period, and we screened them out negative with viral load up front. This was a seroincidence rate of 24%, and this was tragic and devastating to all of us who were doing the study. And what it really speaks to is that we need to have a way to keep these individuals safe during the time period when there is sexualized drug use going on. So how do you keep them safe? Gabriel Rottello did a really good book years ago, somewhat contentious in the LGBT community, but I think it had at least this piece which is accurate. And this is the sexual ecology, the triad of risk, which looks at the infectivity by the route of transmission. So if you're a receptive partner, your risk is many times higher than if you're the insertive partner. You add circumcision, you can reduce the risk from the insertive partner. But essentially, we know that that's mostly stable. Amphetamine changes that because it flips people. The prevalence in a key population, so if you're in a low prevalence versus a high prevalence, if your prevalence among AT users is high, the likelihood of, if you want to think about using circulation theory, of reaching in and getting a dirty shirt, if you will, is going to be much, much higher if the prevalence is 20% versus if it's 2%. All right? And so that is oftentimes fixed in these epidemics that are maturing. And then the one place where you could potentially have some kind of intervention is the contact rate. And one of the reasons why HIV transmission is so great in this population is that there's the sexual disinhibition. The number of sexual partners goes up. Group sex, the entry of new individuals who come into networks, you bring other people in. And so this is a place where dealing with the amphetamine use may actually have an impact. But the great game changer in all of this is that, that there's a couple of other things, is that there's been the introduction of PrEP, pre-exposure prophylaxis, and I could put PEP in there, but it just doesn't get used to the same extent. And pre-exposure prophylaxis has been borne out in numerous studies. In the IPREC study, which was the study that we did, where most of the patients were from Peru, where they're using another stimulant, cocaine, that in this particular study, it resulted in a 50% reduction, but whenever you amortize the number of days that they actually took the PrEP, adherence matters, and that for those individuals who took 4 days or more of PrEP in any given week, they really had a near complete preventive effect with that. So it's a matter of, one, you give it to them, you get about a 50% reduction, you give it to them, and they take it, place where you can intervene, you can actually increase it, the likelihood. Now, we're moving to these longer PrEP applications, these injectables and stuff like that, so this is going to be the game changer here as it relates to PrEP. But it is something that you can begin to do. Then there's the on-demand PrEP studies. At first, they were sort of, the PROUD and the EPER-GAY studies were done. These actually showed a marked reduction in transmission. This is, you take 2 pills on the day that you're going to get laid, so it's Friday night, I'm going to use some meth, and I'm going to take 2 pills, and then I'm going to take it for 24 hours each, after each time that I have unprotected sex. That study was actually sort of denigrated a little bit in the literature because the people were having a lot of sex, so they were taking it at least 4 times a day. They did another study of individuals who were taking it, or who were having less sex, and the preventive effect was absolutely the same. So the bottom line is WHO has now recommended on-demand PrEP. And you can imagine if you're working with weekend warriors who don't want to take a pill every day, they're concerned about side effects or something like that, we do have another sort of armamentarium. The data looks pretty darn good with some of the newer injectable agents, so in individuals who have trouble with dysregulation, this may be a place to do this. I also want to say that if you're going to get your PrEP program out there, you've got to get buy-in, and we've done this study now in 2 places. We did it in the US, where PrEP was just starting to roll up, and we've done it in Ukraine where it hasn't. And we looked at the intention to use PrEP, and one of our postdocs did this very elegant analysis, and really that the number of partners is one of the independent correlates of whether a person is willing or ready to go on to PrEP. But there's what I call 2 pathways. There's the expectancy motivation pathway, and that is, I'm really sort of fatigued of using condoms. I'm tired of that. I call it sometimes the pleasure pathway. You're just tired of all of that safe sex stuff, and by golly, it feels good. And you can imagine it feels even better when you're on amphetamine. And then I'm going to have to move quickly. And then there's the perceived risk. That is, I just don't want to harm myself no matter what. I only use condoms. But just in case the condom breaks, I'm going to use that. So that's the self-motivation, the self-protection pathway. And both of those are increased ways. And I think that if you're going to have your PrEP and get it into the population, you're going to have to sort of use that as a motivating pathway. One of the things that's important, whether you're in Australia, whether you're in Malaysia, whether you're in the US, is you have to look at a very large socio-ecological framework. And so the epidemic stages are going to be different, the public policies, the criminalization of homosexuality or drug use, all of those things are going to be different. And those are going to be major factors for your implementation process. And so I know that you all had a marked implementation process for doing PrEP in New South Wales, but all of these are going to be different, and what you do here may not necessarily apply or get done in the same sort of way. The other thing that's happening that's sort of interesting is that as part of epidemics, people need to move. So in other words, if you have a core group of people who are near my hotel in Potts Point, where there's a lot of amphetamine use and there's a lot of sort of sexualized drug use that's going on, what about the people out in Parramatta or something like that who are coming into this for like a little weekend jag and then back out to the field? They come in, they get stung, they get burned, and then they go back out, and they're sort of hidden, and they're outside of our sort of array of services. Circuit parties are another sort of venue that happens. They're all over the world. People travel from all over the place. 30, 40, 50 countries are often represented. They're high-risk settings for sexualized drug use, people who may not be at risk, in other settings at home, would be like being in Parramatta and coming in, are coming into these settings. There's tons of sex activities around it. There's actually people on Grindr and Scruff and Facebook who are selling all of the drugs that are there, so it's part of the way that we do things. Money boys, or people who are exchanging sex for money, are coming into these settings, and it causes this traveler's phenomenon. This is a really clever thing that Thomas Guadamuz is doing in Thailand, and did it at a big circuit party that's up there. They basically take these hot go-go boys, they put them up here, everybody wants to look at them, but you actually read what they say here. They have some very clever signs and postages, but what they did was they created a kiosk, so you can come in, you can do your risk-based screening, you learn to do your point-of-care self-testing. They let you actually self-test later on. They had actually a high return rate in the mail, so you can follow up. And while you're there, you can get your on-demand PrEP prescribed for you, so it's a high-risk environment. You can get your PrEP, you can get your condoms, you can get your lube, and if you're doing ecstasy, you want your lollipops to keep your tongue lubricated, which is what I need right now. And anyway, and then they also provide online support. And if you're going to use drugs, they actually provide brief counseling, because this all happens as you go in to buy your ticket or to pick up your ticket for the party before all of the activities have gone on. So this is a time to intervene when you're sort of not full. I'm going to skip over this because it's the same idea of movement where you have this core, you have individuals who sort of move in and out of these high-risk environments from communities that are outside. They're sort of stigmatized. They're the people we're not reaching. Everybody in Potts Point, whenever I looked online, they say that they're on PrEP. I'll tell you a little bit about that. They're not always. And they're doing everything right because it is socio-normative. It is a socio-normative thing to be on PrEP. If you are not on PrEP in Sydney, you are irresponsible, is what the sort of the sayings that I heard was. But what happens is that all of this stuff is networked. And so you have a core group of people who are within the core in the center of this, and people come in and move out of that. And they are all linked by smartphones. Every single one of them. This is an outbreak of gonorrhea. This is all linked through smartphones, and that's how people were tracked down. Just to give you an example of what it looks like to go on Grindr, I tried to take people's face off of this. This was in Malaysia. I have a few from here as well. There's all kinds of ways where you can find what you want. A snowman, a snowflake, a diamond. A diamond is selling ice under these sort of settings. What I liked about this first one is I figured this was a person who was marketing to me. He says, no fat, no chubby, no old over 40. So, I mean, all of this stuff can happen under these particular settings. But chilling is a sort of a marker for chemsex. MB is money boy, CF is chem fun. Nice body, looks appealing, huh? All right, here's Malay mix, CF, chem fun, and you can see a number of texts here that's going on here. Raw sex, sex addict, all of these other sorts of things. A slammer is somebody who injects, but he's also going to sell you sex for money. As part of that, all right? So once again, perpetuation potentially of an epidemic. CF fly, chem fun, fly, all right? Threesomes, group sex, and then, of course, flying high. These are some of the images that you can see. What I did was I actually started talking to people here in Sydney, in Potts Point, that's where I'm staying, and one of the things that was very clear to me is everybody has it. So I said, let me just find out if they're really taking it. So I just asked the question, oh, are you taking the generic or the brand name? And people would say, oh, I'm not sure, which one is it? I said, well, if you'll take a picture of it, let me see it. I said, I can tell you which one it is. I'm an HIV doctor. And they say, oh, well, I don't know really where it is. I said, oh, are you at home? And they said, yeah. And I said, oh, you don't keep your medicine at home? It's in my gym bag, or something like that. And the bottom line is it is socially desirable in South Wales, New South Wales to be on PrEP, but they're not necessarily doing what they say that they're doing, all right? In the US, it's just the opposite. We call it PrEP shaming or slut shaming that happens with regard to this. And it's just the opposite. You don't dare put on your profile that you're on PrEP because you are denigrated, because you were said to be promiscuous. You're willing to do really dirty things under that. So context does matter. I'm not going to show any more slides other than to say that, I've learned a lot that's different here because the context, the social norms are different around the use here. I will say that some places are beginning to try to intervene, and they're trying to do it in this online space. This is the Dean Street Clinic, and they're trying to put out their profiles. Grindr shuts them down, by the way. And so we really have to work with these folks, and we've got to get them on board. And their sort of notion is well, put them in jail, do all of these other sorts of things if they're using it, report it to the police, but don't tell us about it. And the bottom line is that we have to really engage them in order to be able to do that, and we need to help them with what do you do under the situation of a sexual assault? What happens if you're actually getting really nervous? What's happening if you're starting to feel a little psychotic or out of body experience? So we need to be very proactive, and we've got to engage people where they are, because people are not just going to come to your drop-in center. Let me just skip through some of this, talk about this very briefly. The behavioral therapies are contingency management seems to work. The problem is that we just don't know the right dose of what to do in these settings in people who are early on. If you can afford a Gucci belt, I'm sorry, you cannot give them enough money in order to make it worthwhile. Maybe some of these sort of fishbowl sort of strategies might work where they're going to win a car or something like that, but probably not these others. So let me just sort of say that this is some work that we're doing. MyFitnessPal is a way that you can sort of lose weight. You actually record stuff. It's meaningful. You go and you track your progress. You're seeing how you're doing. But what if you changed some of the stuff in one of these things and you regulated sleep? Your phone can actually tell you when you're not moving or not moving that much. So you can automate some of these. You can link it to what you're doing. Your heart rate. The way that you use the pattern on the phone can tell you whether you're using a stimulant or not. There are really good patterns that show that. What is your mood? Most of our patients have some kind of depressive symptom and stuff like that. And so what is their mood like? Is that low mood related to when they use? So you can monitor their use. You can actually do it objectively. You can do it by self-report. People don't like to report it. They don't want it on their app. Perhaps patients get skinny. They lose weight. Look at their weight. Look at their dietary intake as part of this. And also, hey, did you take your PrEP? Because that's going to be the way to keep them safe. These things have got to be interactive. They've got to be things that people want to come to. They need rewards. The rewards are that you're doing well. I can tell you that when I use MyFitnessPal, I have lost the same 10 pounds every time I've done this. And it works for a while. I mean, I have probably lost 1,000 pounds over my lifetime. But this is what we want people to do. We want them to go and we want them to reduce, not necessarily eliminate, and that's what we do with most of our studies. Let me just skip through and basically say that the pharmacological studies that we've done, I don't need this. The pharmacological studies that we've done have basically, they're just not working. It's probably there's a number of different reasons. There's at least 50 to 60% dropout in all of these studies. We're not sure that we always have the right population. We're looking at people at the end of the spectrum. We have to sort of make sure that we've got affirming services in our communities. That's going to work in a place like Sydney. That's going to work in a place like Kuala Lumpur. But is it going to work for the people in Parramatta? Is it going to work for the people out in the rural communities? How are we going to reach them? And I think that we have to have ways that are not driving them underground. The last thing we want to do is make the mistake we did with bathhouses and close them down, or the way that certain people in the gay community are shutting out people who use meth users. It is our community, and we need to engage, and we need to not be judgmental. We can choose not to have sex with somebody who's using that, but we need to engage and say, hey, maybe have you talked about trying to get use, as opposed to sort of shutting out entire groups of individuals. So we need those affirming services, and we really have to take our interventions, what little bit that we know that work, and we need to meet individuals where they are, because that's how they're finding each other. Thank you very much.
Thank you for. Look, I found that talk absolutely fabulous and stimulating, and I'm sure everyone else did. But can you just be available for questions at lunchtime, because we're running behind? Thank you. That was great. Thank you. Next up, we've got Amy Peacock, who you've already met this morning. She's back with more.
Okay, great. So thank you for having me back again. I'm very excited. I'm going to be here today talking to you about the most recent findings from drug trends. Now, before I start, I do have the opportunity to stand up here and talk to you, but I am talking about the work of a lot of people. So I'd just like to start off by acknowledging the people here at NDARC who've contributed to the program of research, but also across Australia, and also in previous years to this program of work, because it has been running for a long time. And in particular, I'd really like to thank the participants that we talked to for both of our projects that have provided the data that we're covering today. So drug trends. Drug trends is an illicit drug monitoring system that's been running here at NDARC for over 2 decades now. And the core aim of drugs trends is to try and identify what's happening with illicit drugs in terms of patterns of use, markets, and harms. Now, to do that, we cover quite an array of data sources. There is some primary data collection where we talk with people who regularly use drugs as part of the illicit drug reporting system and the ecstasy and related drug reporting system. But we also analyse a range of routinely collected administrative data, as well as undertaking some extraction and analysis of new unique data sources like online markets. Now, if I tried to cover all of that today, we could be here until, well, I won't even try and guess. So I'm just going to focus on our findings from the interviews with people who regularly use drugs, and also some of our analyses of the national routinely collected data sources, including hospitalisations and mortality. So to give you an idea of the samples that we're talking about when we're talking about our interviews with people who use drugs. So for the IDRS, we normally try and interview around 900 people each year who regularly inject drugs, and we're trying to recruit them from capital cities across Australia. With the EDRS, it's a slightly different population. It's a group of people who are regularly using ecstasy and related stimulants, also recruited from capital cities. Now, when you look at the characteristics of these two samples, you can see that they're quite different populations. So with the sample who are regularly injecting drugs, they're somewhat older, and there's really quite high rates of disadvantage in terms of educational attainment, employment, and also encounters with incarceration. By contrast, the EDRS sample, so those who are engaging with, who are using ecstasy regularly, they're more likely to be employed, to be studying, and they're less likely to experience problems around homelessness and whatnot. So before I get into the findings, I just want to flag a few caveats to this. So we are talking about sentinel samples of people who use drugs. This means that it doesn't necessarily represent everyone who uses drugs, nor does it represent use in the general population. We're also relying on what people tell us they bought substances as. So we don't have objective information about the substances that they actually have consumed, where there might be a discrepancy between the expected and actual substance. And finally, this is one source of information. We do need to consider this data alongside other data sources, and I'm going to try and integrate that in the presentation today. It's a pretty exciting day for us. So this is, each year we get to release these findings. It's a lot of work, and there's always so much to talk about. And traditionally with this presentation, we've got, 20 minutes? Go on, a bit extra? No, 20 minutes. We've got 20 minutes to talk, and it's really hard to just cram lots of figures in. So I've decided to take a slightly different tack this year. I'm going to give you the top 10 drug trends of 2019. Now, in a traditional countdown, it'd be a democracy, you'd all get to vote, what are the best trends? Sorry, a bit of a dictatorship going on here. But please, I can encourage you to go to the reports and see whether you agree that these are the most interesting trends. I was hoping to get some background music, the final countdown, but it was always going to mess up, wasn't it? So let's start with number 10. And these aren't necessarily in order. Number 10, cocaine. So, looking at our sample who regularly use ecstasy, last year we reported to you that in that sample we saw that recent use of cocaine went up, and as we expected, it's gone up again. So it's around 2 in 3 of our sample who regularly use ecstasy who report also using cocaine in the last 6 months. Looking at the sample who regularly inject drugs, you can see that use of cocaine sat relatively stable amongst that group. Now, the thing to note with cocaine, we do want to have a look and see what's happening with patterns of use, market features and harms. And when we look at this, we see that most people are reporting using cocaine infrequently amongst that sample who are regularly using illicit stimulants. The price has also sat stable over the last couple of years, which is interesting. However, we have seen reports of availability go up. And this is taking this into account looking internationally. So internationally, we're seeing increasing reports of cocaine manufacture, and indeed there's some reports that they're at record highs. And when we look at some of the other countries, so for example, England, they're seeing increasing reports of use, increasing treatment episodes, and actually record highs in terms of cocaine-induced deaths. Now, the distinction here is that in England and say in the US as well, we see much more reports of use of crack cocaine. In Australia, when we ask participants about the form that they're using, it's typically, in all cases, the powder cocaine form. So looking across other indicators here in Australia, turning to law enforcement data, it does seem to suggest from that indicator that we might be seeing increased availability in terms of increased number of seizures. And there's also reports of increased arrests related to cocaine as well. But I guess the important thing is what's happening with harms if we are seeing increased availability and potentially increased use. Looking across the data sources, so in our analyses, preliminary analyses of hospitalisations data, cocaine is only a very small proportion of the total drug-related hospitalisations. It's a small proportion of treatment episodes, and it's involved in a small number of drug-related deaths. But I think this is something we really need to keep an eye on. With the reports of increased availability, potentially increased use amongst our sample, we need to see what's happening more broadly. And also if we see changes in price and frequency of use, that's where we might see changes in harms. Number 9, ketamine. All right, so ketamine. We've seen a bit of an increase in ketamine relative to 2018. So it's around 2 in 5 in our sample of people who regularly use ecstasy who have used ketamine in the last 6 months. And I just wanted to put LSD there for context so you can see that overall in terms of use of hallucinogens, we are seeing a bit of an upwards trend over time. Again, coming back to the point I made before though, use is relatively infrequent, so people are generally saying on a monthly or less frequent basis that they're using these substances. The other thing is Australia's a pretty big country, and so to draw a national picture from these data can sometimes be a little bit misleading. LSD, when we look at across the jurisdictions in our samples in each capital city, it's roughly similar numbers, so it's around 43 to 53%, I think it is, who report recent use of cocaine across the jurisdictions. When we look at ketamine, it's quite a different picture. So it ranges from around 17% in Tasmania up to 84% in Victoria. And typically it's the more populous jurisdictions, so New South Wales and Victoria, who have been reporting higher rates of use. Now, as I mentioned, frequency of use still stays quite low, but given this increasing use of ketamine in our sample, it does speak to some really important harm reduction messages that we might need to focus on. So things like avoiding alcohol with ketamine, as we've talked about, can be quite dangerous in terms of potential risk of overdose. Ketamine can impact balance, coordination. It's not great to drive. It's not great to be in an unsafe situation where people can be at risk of injury. And there's also issues with potential urinary tract issues with ongoing use. The next one, e-cigarettes, so a pretty hot topic at the moment. We've been monitoring e-cigarettes for a number of years, and I've just put tobacco there as a comparison point for you, and this is across both of the samples. So we've seen around with our sample who inject drugs, around 1 in 5 report any recent use of e-cigarettes. In our sample who regularly use ecstasy, it's more around 2 in 5, and that has been starting to creep up a little bit in the last year or two. Now, the reason why e-cigarettes are such a big concern at the moment, and I won't steal Hayden's thunder, I think. There has been a lot of discussion around what's happening in the US. So there's been more than 1,000 cases of lung injury from the US around e-cigarettes or vaping products, and around 26 deaths have been recorded so far. So this is of concern, and it's particularly in relation to use of cannabis with e-cigarettes. So when we look into the data a little bit more, we can see that with our EDRS sample, they're typically using e-cigarettes relatively infrequently. So tobacco is the more frequently used substance amongst this sample. When we ask them about what they think or what they consumed the e-cigarettes as last time, we see that most people say that they were consuming e-cigarettes with nicotine. There are small reports of using it with cannabis. And I guess that 11% there is a little bit interesting as well. The neither in terms of whether it's no psychoactive substance or something else that people might be vaping, and something we want to look into. And this is just referring to previous work that's been done by Rachel Sutherland and is published. So Rachel did some work looking at the patterns of use among the IDRS and EDRS sample back in 2015. And that data really seemed to suggest that for IDRS, they were more using it as a smoking cessation tool, whereas the EDRS sample, it was more around the recreational or experimental type use. And that would be reinforced here with the frequency of use that we see. Number 7, opioids. You can't do a countdown without opioids, can you really? So looking at opioids, so again, national picture, heroin sat relatively stable in our sample over time. What is interesting is looking at non-prescribed use of pharmaceutical opioids. So we've really seen morphine and also oxycodone to some degree come down in terms of the percentage reporting recent non-prescribed use. Fentanyl is another big topic of interest at the moment. It's roughly around 1 in 10 of our sample who report using non-prescribed fentanyl, typically on a relatively infrequent basis. What is interesting, and also to flag, we also looked at some other opioids this year. So we looked at non-prescribed use of codeine, so it was around 1 in 10 who said they'd use codeine non-prescribed, but also non-prescribed use of some of the newer opioids like tramadol and tapentadol, and they typically are relatively infrequently used as well. But just coming back to that idea of the jurisdictional differences, so looking at heroin in particular, it's quite striking to consider across our samples from the various jurisdictions. So when we look up at the NT, it's less than 5% of the NT sample who report recent use, all the way up to 85% in Victoria, with similar high numbers in New South Wales. And what I haven't shown it here, if I could put the flip here in terms of showing you non-prescribed morphine use, you would see that Tasmania and NT have higher rates of non-prescribed morphine use, so it's around 40% in the NT that report non-prescribed use. Hopefully this has come up okay, but the reason why we really want to keep an eye on heroin is if we look at our most recent reporting on drug-induced deaths in Australia, so this is up until 2017, we can see that natural and semi-synthetic opioids, so that's things like morphine and oxycodone, have really been leading the way in terms of driving opioid deaths. But heroin in that aqua blue has been sneaking up, and that's something that we will continue to monitor. We will have the 2018 findings released in mid-November, so we will look and see what's happening with heroin then. But the other thing I want to flag is just how important it is to consider what else is going on with these deaths. So when we look at our opioid-induced deaths that occurred in 2017, looking at other pharmaceuticals that have a sedative effect that are arising, and also alcohol, it's very rare to see these opioid deaths arising in isolation without other drugs, which leads nicely into number 6. We're nearly halfway. Overdose and naloxone. So another important component of our sample of people who inject drugs is monitoring their awareness. Oh no, sorry, a little bit excited about the 5 minutes. Is their awareness of naloxone. So we can see that most of our sample are aware of naloxone, they've heard about the take-home programs, and on a really positive note, we've seen an increase in the number who are trained in naloxone. If we want to look at that across the jurisdictions again, we can see that it does vary across the jurisdictions, with some showing an increase in awareness in recent years, so particularly in New South Wales and Queensland. And the reason why this is so important, and if we ever wanted to justify naloxone, I think we could do it based on the IDRS sample alone. So when we look at it, we see that 3 in 20 participants reported an opioid overdose in the last year in 2019. 1 in 20 participants had been resuscitated with naloxone by someone who'd been participated in a take-home naloxone program. And 47% of those participants who reported participating in a program had used naloxone to resuscitate someone. So it's going to be interesting to see what happens with the availability of the intranasal spray, and we'll continue to monitor that with this sample as well. Oh God, 5. Okay, 5. Talking about service engagement, so really quickly, as I mentioned before, they're quite different samples. So with our sample who inject drugs, there's relatively high rates of drug treatment engagement, although I will flag that there was an additional percentage who said they had not accessed treatment but that thought they needed it, and of that percentage, 33% said they tried but couldn't get access to treatment. So there is a recognition of an unmet treatment need there. Similarly, we see that it's around a third of our sample in both cases that have engaged with a mental health professional in the last 12 months, but it's up around a half of our sample who actually report having a mental health problem. So again, a bit of a gap there. And this year we asked both sample about their sexual health behaviours as well. And notably, it was somewhere around half of each sample who reported having a sexual health check in the past 12 months, although we did see reports of engagement in what could be considered sexual risky behaviour in terms of penetrative sex without a barrier where they didn't know their partner's status. Number 4, modes of purchasing. So this is looking at how people have purchased their illicit or non-prescribed drugs in the last 12 months. So when we asked them about the last 12 months, the majority of them said that they organised their purchase face-to-face, although it was around 3 in 4 who said they used social networking sites, Facebook, WhatsApp and whatnot. Around 1 in 10 said that they had used darknet marketplaces to buy drugs. We also asked them in very vague terms how they have received their illicit or non-prescribed drugs in the past 12 months, and overwhelmingly they said that at some point they had received their drugs face-to-face, a smaller percentage through the post, and 1 in 10 said via a collection point where you say the drug will be there, come and get it at some point in time. And finally, looking at our sample, so as I mentioned, there was around 1 in 10 who reported buying on the darknet, around 1 in 20 who reported buying on the surface web marketplaces. So when we asked those people, when you bought online, were you intending to give that drug to someone else? And it was around 60% who said that they intended to supply that drug to someone else. Number 3, ecstasy, because ecstasy and related drug reporting system, you can't miss out on ecstasy. So this year it's a little bit, there's a notable finding there, although it's hidden in a quite dense graph, and that is that we see capsules overtake pills as the form most used in this sample. It's quite interesting digging down into those results. So we've seen median days of capsule use increase, we've seen the price go down, so it's now $20 a capsule, whereas a pill sits stable around 25. And we've also seen perceived availability go up, where we haven't seen the same for pills. Something else that's of interest, particularly given the coroner's inquest at the moment into the deaths arising at music festivals, is the quantity that people are consuming. So we see that when we ask people about the typical amount and they have it in a session, they're typically having 2 pills or 2 capsules, but their maximum amount that they'll consume in a session is 4. This is a sample of people who are regularly using ecstasy, so it is important to take that into consideration. Looking at other behaviours, so when we asked them about their last stimulant use, there were it was 90% of them said they used another drug when they last had a stimulant. And I think the figure that's of concern in this image is that 5% in the middle. So those 5%, that 1 in 20 had a stimulant, a depressant, cannabis, and a hallucinogen in their last session. But on the flip side, we also asked people, last time you used ecstasy or related drug, what strategies did you do to try and reduce your risk of harm? And the majority of people said they actively did something to try and reduce their risk of harm. So when we look into it, of the total sample, it's around a quarter who searched their drug online or who searched online for drug interactions, who used vitamin supplements. 61% said they talked with other people who had used drugs out of the same batch to try and get information. So I think it's important here to note that people are actively trying to get information and to engage in these behaviours to reduce their risk, which is going to lead quite nicely into number 2 and 1. Number 2, music festivals. So we asked our sample who regularly use ecstasy, had they been to a music festival, and 68% of them said they had been to an Australian music festival in the last year. Now, hopefully this number doesn't surprise anyone. And this is a sample of people who regularly use ecstasy. So 93% of them had used an illicit drug at their last music festival. 83% had used alcohol, to take into note there too. 5% of them at their last music festival thought they needed medical help following their illicit drug use, and 2% of them sought medical help. Now, moving to the next slide, I think it is quite reassuring when we ask people about their last festival, what were they aware of that was in place in terms of health, policing, security initiatives and whatnot. So people were aware of on-site medical services. They were aware of roaming first aid and whatnot. They were also very aware of policing and security initiatives at festivals, so bag checking, police drug detection dogs, police patrolling. What I think is interesting and where we could potentially focus our attention is their awareness of drug information services and harm reduction messaging at festival. So this is a sample of people who regularly use ecstasy when related drugs. This sample is not engaged typically with alcohol and drug services. I think if we can look to see if there's increased access and increased awareness of these services at festivals, it may be a way that we can reach this group. Have I got time for number one? No. God. Okay, could it be anything else? Drug checking. So this year we asked people in both samples about their engagement in drug checking. So 1 in 10 of our sample who regularly inject drugs, who haven't really featured in the discussion in Australia, report ever testing their drugs. And 4 in 10 in our EDR, 45% in our EDRS sample report ever testing their drugs. And 36% had done so in the past year. Now, as you might expect, the majority of these people reported using personal testing kits to test their drugs. So these are things like chemical reagent tests that they can purchase. So a chemical reagent test, you probably won't be able to see the specific drugs and colours, but essentially you add a reagent liquid to the drug, a bit of the drug, and it turns a certain colour to indicate what drug that's likely to be. When we got down into our EDRS sample and started to talk to the people who'd used a personal testing kit on ecstasy, we found that the majority of them said the last time they tested ecstasy or MDMA, they detected MDMA. So it was 88% who said MDMA expected and detected, 8% who said expected and didn't detect, and a number of people who said didn't know. As you'll see here, most of the people who expected and detected MDMA went on to use the drug. However, I think it's quite interesting as well to see that percentage of people who are sharing the information. They're sharing with friends, they're reporting it on forums. So it is, in turn, impacting potentially on other people's consumption. So with the use of these personal testing kits, and not to go into it too great a depth, but it is important to note that this signals to us people want information. It tells them about the presence or absence of a drug. They're relatively low cost, they require relatively low tech expertise, and they are legal to purchase. However, there are some caveats to this. So it tells people about the presence or absence of a drug, but it doesn't tell them about the full array of substances that might be contained, nor about the dose. So it's not the full array of information that people might need. It also comes down a little bit to subjective interpretation and how good you are at picking colours. I don't know how people with colour blindness go. Anyway, and then also, I guess, in terms of talking about fixed site drug checking, there is the option as well for people to receive harm reduction information from professionals. So in this case, with personal testing kits, they're likely interpreted in isolation. So that was my top 10. Hopefully you agree with it. If not, head to our reports and you can see if you think something else should have been in there. You have copies of the infographics in your satchels. We also, if you want more information, have one-page bulletins on drug checking, on festivals, and also on crystal methamphetamine commercial ball pipes, which Tony is going to talk a little bit more about. And if you want more, there's lots of sessions today. And finally, if you still want more, you can contact us. Thanks.
Thanks, Amy. I'm not going to take questions, but I'm sure Amy's happy to hang around and talk more drug trends at lunch. I'm apologising sincerely. We will be going over, but I did think it was well worth waiting to hear the top 1 and 2, so didn't cut Amy off there. We've been waiting for months for these results. So now I'm pleased to present Sandra Mitchell, who's going to be talking about our aspirational work with the Prompt Response Network. Thanks, Sandy.
Thanks, Nadine, and thanks everyone for inviting me today. So I'm going to talk about my work at NCCRED, which is the National Center for Clinical Research in Emerging Drugs, and the Prompt Response Network. So the National Center, the aim of the National Center is to reduce the gap between clinical research and clinical practice and look at ways that we can bring in what we learn from research into the clinical practice and prevent things from happening and have golden standards for practice. The NCCRED is built as a consortium, and it's got 4 partners, NCCRED, NDARC, NIDRI, and St. Vincent's, Australia. So the aim of the National Centre is to generate new evidence based on knowledge. So looking at the research, conducting research, and looking at some hot topics. It's also looking at building that clinical capacity. So looking at building clinical research and supporting clinical research with our seed grants and our capacity building grants. So it's looking at collaboration with organizations in clinical practice so that we can work with them and do the research right in the clinical settings so that we can encourage and support those areas of research. And with that, we're also looking at the knowledge translation, so making sure that we've got that, the information that we're getting from the research, we're able to transmit that and get that knowledge out there to the clinical settings and implement it into practice. So the background for the Prompt Response Network, which I'm going to be talking about, is recently with the disorganized responses to the recent events that have been occurring, it sort of highlighted the urgency for a national coordinated network that can respond to events of concern. So we're looking at developing a national network that will highlight and respond to events. In the recent study that was done from Amy, the increasing proportion of people who use ecstasy and stimulants are also taking unknown substances. So that is really important when we're looking at getting that information out there real time. So when events are happening and when things are happening, making sure that people are aware and people can be prepared. So in Australia, with the recent events of concern, there's been informal networks that have come forward to get that information out there. So looking at whether it be Twitter or on forums, but as Amy said, they've developed these informal networks to get the information out there because they've realized it's been a real urgency to get that message out there so people can be safe when they're using. So looking at what those informal networks and bringing those together in a national sense, and also looking at what we can learn from what's happening internationally and the platforms and the networks that are currently running internationally. We're looking at developing something in Australia. So this is in 2013 in British Columbia, they developed the DOPE, which is the Drug Overdose and Alert Partnership. And this is a network and a partnership that is working really well. And so we're looking at what lessons we can learn from this. This partnership is a closed network, so they really stress the importance of having it as a closed network. So you get a login, you log into the network, and it really sort of gave the key stakeholders that are involved in that network, the sense of confidence and the trust that the information that they're providing is going to stay within that network until they decide and come up with a communication and strategy plan to make it public. They really, really needed that that confidence that it's not just going to be accessible to everybody. So they've gone along and developed it. It's been running since 2013 and successfully. The interesting thing with this partnership as well is that when people sign up to receive alerts from this partnership, they'll identify at that time how they want to receive the alerts. So whether it be text message, email, Twitter, Facebook, whatever their social platform that they're accessible or they're accessing, this network will be able to provide them a text message that with the information that's going out there. The interesting thing right now that they're looking at is because of the fentanyl crises and that's happening, they're looking at how much and how frequently they can put those alerts out there until people are getting overburdened and starting to ignore the messages. Like they could realistically be putting out an alert twice a day or not, but these are things that they're having to look at right now so that they don't overburden the messaging, and looking at whether a sort of a weekly summary of what's going on is more effective than having sort of a daily alert system. The other thing that's interesting with this closed net partnership is that they have a forum as well. So you'll see in my next slide, these are how often people put in reports and what reports they're putting in. So you can see sort of like the coroner services is putting in a monthly report into this partnership. But then they're having that report 2 to 3 days before it's being made public available to the public. So what's happening is that these key people in this network have that information and can be prepared for the information that's going to be released to the public. So drug checking are putting in weekly reports on what they're finding out there in the community and the different services. The interesting with that is these key stakeholders are putting in these reports on a monthly, weekly basis because that's what they've deemed to be sort of relevant, but they also have, as part of this network, an online forum so they can discuss any hot topics like amongst itself. And it's not a moderated forum. They've got trust within their network that the forum is going to be effective and it's not going to be misused. So they have this forum that they can say, hey, I'm noticing blue pills here, or I'm noticing this, is anyone else noticing this, and just talking amongst themselves to sort of identify some trends and some patterns, which is quite interesting. So learning from that, we're hoping to bring in those lessons learned from the international platforms, as well as taking in those informal platforms that are being developed in Australia and bringing them together in a national response that can inform policy and practice and provide that important public health messaging for people that are trying to stay safe while they're using, and for the public. So this prompt response network that I've been talking about is going to be a circle of communication. So we're going to be having notifications in with different various platforms, and well as providing communication out. What we're developing in Australia is going to be a moderated platform so that we can identify any myths that come through, or false information, and also then be able to identify the risk, whether it's high risk, low risk, or already confirmed. So this is this is a very in infancy stage, so it's probably the end product won't look like this, but this is what we're in the midst of developing. We've come up with the name of DrugWire, and it's going to be very basic with alerts where you can submit a report, a little bit of information about the network, and how to contact us through an email if they want to get any more information. So DrugWire, the importance of it is providing that real-time information out to healthcare providers, out to the public, so that they can be prepared for these events of concern. And with this, with all the information that's coming in, and the moderated response, which I'll show you in a minute, we hope that from the information, the report that comes into us, to the action, whether it be filing it to a database or whether it putting an alert out, we're hoping that whole process, our aim is to have that within 24 hours. So really real time getting that information out so people can be safe. So this is the proposed model so far. So as you can see, we're going to be bringing in reports from all different types of platforms. And when somebody does a report, they'll get an automated response saying that thank you for your information, and this is where you can go to see where your what's happened as a result of your report, whether an alert has been put out because of that or how that information has been used. We're also going to be actively monitoring the informal platforms that already exist, as well as the international platforms, to see if there's any trends or we can see any kind of clusters building that are important for us. Once those reports come in, they're going to be moderated so that they'll either be validated or not validated or already confirmed. And if it's not validated and already confirmed, then it'll be put into our database so that we can start to see if there's any clustering or if that information can be used in the future. And if it's validated, then we will go on to continue to have another moderation process to see if it's going to be considered high risk or low risk. If low risk, then what sort of we'll sit and watch, and we won't do any further action with that. But if it's going to be a moderate or high risk to the community or to people, the public, we're going to put it through to the jurisdiction to come up with a communication, a plan and strategy. And so we're envisioning that there's going to be 2 different levels of alerts that come from that. So alerts with advice or advisories with advice. And then, of course, that information will be filed, and then we'll be continued to watch that space. So the features of the Drug Wire is that it's going to be community focused. It's going to bring together a whole bunch of already informal networks that are existing, as well as key stakeholders, and going to be really encouraging engagement from different areas to be involved with it. And so this is just, once again, the infancy stage of what it's going to look like. But we're going to have, so far, we're thinking of having 2 report forms. This is the feedback that we've got, sort of a your experience, so very low barrier narrative. They can put in words about what their experience, what they're concerned about, the date, and sort of what happened, whether it was a friend, whether it was them, or whatever information that they want to give us. They can just type it in free narratively. And then we're also going to have a more clinically based form that gets a bit more information about the appearance of the drug, where they sourced the drug, and what actually was the outcome of the event, and whatever information. The information there is going to be, you can fill out as much or as little as you can provide. Obviously, we encourage people to fill out as much as possible, but we don't want to make that a barrier. So if they don't have the information of who it was or that, it's not going to be a barrier. And then, yes, the research opportunities that have come forward out of the priority setting that NCCRED did earlier this year. It came across the importance of doing the feasibility of social media and different platforms that are going to be consumer focused. So looking at how we can take those messages out to the people that are using drugs, and what's going to be the most readily accessible platform for them. So as the example of Vancouver, like text messaging was the big one. So looking if they want to receive a text message from their smartphones. Also evaluating the feasibility of this network and how effective it can be in getting that messaging out within 24 hours of when something's happening. And then also the effectiveness and possible behavior change with these messages. So next step is to, we've got a network of key stakeholders. It's in the process of being built, and we're hoping to put the pilot out of this early next year, and by mid next year have it out for the general public. And thank you. So watch this space, and we look forward to hearing more.